So welcome everybody. This is a very exciting evening and is a joint venture between the International Child Health Group and the WHAM team. And it's my great pleasure to introduce you all to Guddi, who is going to take the lead on this session, which we hope is going to be a really dynamic and exciting session full of lots of discussion and lots of opportunity for interactivity altogether. I should have said, for those who don't know me, I'm Sammy, and I'm one of the co-leads for the education and training group for ICHG, and joined by lots of lovely members of ICHG and WHAM all together. So over to you, Guddi.
Thanks, Sammy. So first of all, good evening, everyone. It's such a pleasure that you've all decided to join us this evening. And as Sammy said, a very welcome. My name is Dr. Guddi Singh. I'm a paediatrician, but I'm also a researcher and broadcaster, which will come up a bit later. And I also lead this organization called WHAM. So it's the Wellbeing and Health Action Movement, which I hope you've heard of. But this is why we also call our webinars WHAMinars, and this is going to be the title of WHAMinar with ICHG, which stands for the International Child Health Group at the Royal College of Paediatrics and Child Health. And tonight we're discussing a really big topic. It's titled Global Problems, Local Pressures, Justice and Child Health in a Fractured World. Now, before we dive in, let me just quickly sketch out the shape of the evening so you know what to expect. What we're going to start off with is a conversation between myself and our two brilliant speakers. And then we're going to be exploring issues about how they show up in different contexts. Then what I'd like us to do is to move the conversation wider and invite contributions from the audience before we all break out into smaller breakout rooms for reflections. And that's where it's really your opportunity to share your own experiences, to swap ideas, and to grapple with some ethical dilemmas, which we might just plant into those rooms when you break out. And finally, I'd like us all to come back together so that we can share those key insights. And we'll hear some more closing thoughts from our wonderful panel. And then we can then look at what's on the cards for both WHAM and ICHG at the end. So the point is that this evening is a space, yes, for learning and listening, but also for participating. And I hope that you will leave tonight with insights, but also some solidarity with people who are doing this work with you, and possibly even some inspiration. Now, Sammy, if you wouldn't mind starting to share the slides. I just wanted to say a quick few words because I realised that tonight we're joined by two different audiences. We've got the WHAM membership and we've got ICHG's membership. And so I thought it might just be helpful for the ICHG lot to just learn a little bit about WHAM because you might not know about us. Just let me know when you're sharing.
Yep, can you see
Yay, yeah, lovely, thank you. So for those of you who are new to WHAM, we are a digital platform and a community that's been built by clinicians so that we can provide each other with the tools and the knowledge and solidarity to tackle health inequalities together in practice. So you can think of WHAM very much as practical modules that you can maybe use in your day-to-day practice, but also as peer support by colleagues who get it. And more importantly, it's the place to try and turn moral distress into moral action. Next slide, please, Sammy. We are really all about turning intention into impact. And if you are one of those clinicians who wants to do more than just learn about things and actually do things in practice, then this is definitely the place for you. Next slide, please, Sammy. Now, after a little pause, we were actually relaunching our webinar series, and this evening is exactly that. What we're trying to do is we're connecting and reflecting and thinking about those bigger forces that shape child health. Now, we're going to be running these webinars monthly, so please stay tuned for our program, which will be on our website soon. And I'd really love it for you to join the conversation with us. Next slide, please. Now, I'm speaking to you tonight on what is a very exciting day for me because my BBC series, 3 Ages of Child, which was on BBC Radio 4, launched earlier today. Now, the reason I'm bringing it up is because it's highly relevant to what we're talking about today. It explores some of the most basic conditions that children need to thrive: housing, food, education, stability. I don't need to tell any of you that those are the social determinants of health, and they are what shape children's health and futures. Now, this series, I think, is one of the very first attempts to try and bring the social determinants for health to a wide, broad mass audience. And it's also really helpful for showing what happens to professionals like us when we are scrambling in conditions where these things are not being delivered to the population, and how we are having to try and deal with them in overstretched systems. So I think it will really resonate with everyone here and absolutely resonates with the theme of tonight's show. Now, I'm having to do a little plug here because, well, I'll tell you why. Because it took 18 months to make this show because I was told that people are not interested in children and they are not interested in inequality. Now, the fact that this series exists at all is a small victory, but the truth is that there's been next to no investment in publicizing it. And the only way that there can ever be any real impact is if we share the story and we try and reach the ears of people who are in power and who are in policy making. So I'm just going to ask for you all to scan that QR code. Please share, download, tell everyone about it because every time we do that, we are sending a very powerful signal to the media and to the people who are in power that mainstream institutions need to keep these things on the agenda and that these are important conversations and that we do care. Conversations a bit like tonight, for instance. So that brings us to tonight's webinar, and I'd like to thank you all for giving your energy to being here today, whether you are a seasoned global health practitioner or if you're just starting out. Now, today, like I said, we're tackling that topic of global health problems, but local pressures. And so what I would like us to do is to think about whether you're at home in the UK thinking about austerity and inequality, just like my radio series, or you're thinking about resource poor settings where we are, as health professionals, are trying to navigate the moral distress and professional responsibility that comes with working. What we're doing in all of those situations is thinking about what do we do when the systems that we're working in are under strain. So I'm joined tonight by two amazing guests. Next slide, please. First, we have Dr. Mark Schreim, who is the editor-in-chief of BMJ Global Health. He is a leading voice in global surgery and health equity and the author of the book Solving for Why, a surgeon's journey to discovering the transformative power of purpose. Now, next slide. Not only is this man at the forefront of global health, but he also used to be in a funk band with me when we were at the Harvard School of Public Health many years ago. I'm sorry, Mark, I didn't warn you about this, but the reason I put this here is to show you that we are human and that there is so much more to us than meets the eye. Now, we're particularly thankful to Mark because he's joining us from a mercy ship somewhere off the coast of Sierra Leone, I think. So thank you, Mark, for being here. Next slide. Our second guest is the wonderful Dr. Maria van Velen, who is a frontline practitioner who actually started as a nurse before coming into pediatrics training. And her work has spanned different organizations, different contexts, and her insights are going to help to bring into sharp relief what it means to serve children and families when resources are constrained. So we could stop the slides for now, Sammy. Brilliant, lovely, thank you. Now, if Mark can forgive me for those photos, then we can carry on. So, Mark, Maria, first of all, thank you so much for being here. And now, to kick us off, when we think about tonight's theme, which is justice and health in a fractured world, big sounding topic. I'm wondering what it brings up for both of you in your own work. And this is just to open up the conversation and allow everyone to hear a bit about you, what you do, and why you're coming to this conversation, really. And if it's okay, Mark, I'd like to start with Maria first.
I think it's really crucial, especially some of the things we talked about, Guddi, in the past. So I foster children currently in England, and you see a lot of the justice and health issues that you usually would only encounter in developing countries. You see all the time in developed countries in both the States and the UK. And it's, really disheartening that areas that I've worked in, such as Chennai, in India, you have on one side of the street, a brand new shopping mall, and then the other side of the street, the orphanage that I'm working in. You're starting to get a little bit of those factors. I would say a little bit more in the US than the UK, but definitely more nearby in the UK. And it's really important for people to be aware of the inequalities, both, within their surrounding town and city. So it's not really, it's exactly what you said about the three ages of child, the intense need for children in care in the UK isn't advertised very well. It isn't in the media. People don't realize how many children aren't being taken care of right now. and really need carers in the UK. So I think it's really important to address both issues.
Thanks, Maria. That's a very personal reflection too, and thank you for sharing that. Mark, what do you have to say to this?
Yeah, first of all, Guddi, thanks for inviting me. And Maria, it's great to be here on this panel with you. The first thing that came to my mind as you were talking about this. So, as you said, I'm a surgeon. I'm not a pediatrician. Um, and I do a lot of my work in primarily in West Africa, although in other countries as well. And when I started doing this work nearly 20 years ago, I come to these ships and I have these big tumors that I take out. And the initial reaction when you talk about these things and the initial reaction when you see them is there's something strange, weird. There's something about Africa, in quotes. Why? Because we never see these sorts of tumors in the US. Then I will admit it took me an embarrassingly long time to come to this realization. But the tumors that I'm taking out here are exactly the same thing as the tumors that I take out in the States. Pathologically, the exact same tumors. The reason that they grow so big here is a lack of access. So then that led me in my career to okay, well, why is there a lack of access? There's financial risk, there's, the road networks, there's XYZ, which for a long time in my career, that was kind of the why that I was pursuing. But the injustice takes it even one level higher. And that's to recognize that the lack of road networks and the lack of surgical personnel, whatever, is not even the why. It's the how of how the injustice is manifested. The why gets even deeper. Why is it that road networks are worse? Why is it that education systems are worse? And that is where the actual fundamental injustice sits. And I think that's where the fundamental injustice that those of us who work in these spaces should be talking about and thinking about, in addition to all the other things.
Amazing. So we didn't discuss this before, but what I love about what you have both done is that you've bookended this in exactly the way that it needs to be, which is that Mark, in true editor-in-chief mode, you've taken that high-level view and you've given us what are the structural determinants of health here, right? You've talked about systems. You've talked about the basic things that are not, if they're not present, then everyone else we can just all say goodbye, right? Because health can't exist without some of those basic things that you talk about. So we talk about the structural political determinants of health. And then Maria brought it home in the very personal there about what is it like to try and care for a child who has basically been failed by society in one way or another, right? And so these are the two extremes that we work within as health professionals. At the very personal, individual level, when we're seeing patients in front of us, or in some cases, literally caring for some of these people. And then in this other way, when some of us will branch out of our clinical practice to think about public health, to think about policy, to think about operating in these different contexts. And that's where we have to try and think, well, what's the bridge? How do we connect these worlds together? And that's really why WHAM exists, but that's also why places like ICHG exist, because these are questions that apply across all clinical contexts. So on that note of trying to think about bridging the personal and the political and the big and the small, Mark, we've talked before about some of the ways that we frame health, right? In discussion, we talk about health as it being like the ultimate good that all patients should be prioritizing. And yet, I know that that's not always how it pans out in real life, right? Patients, quite understandably, make different value choices, whether it's livelihood, survival. And I just wonder whether you could tell a story that would help to bring that to life for everybody who's listening, and then how you can manage that tension in real life as well.
Yeah, it's such a good question. And there's so much behind your question. You might just have to cut me off if I start talking for too long. But those of us who are in health feel like, well, of course, if you don't have your health, you have nothing else. Like health is wealth, to use the American expression. So we should be prioritizing health. In fact, one of the professors that Guddi and I both had in grad school used to call health a special good. And it was even more of a good than all the other goods that are out there. And it had a moral place in his sort of constellations. But then when you actually take the time to talk to patients, and I say this, when you actually take the time, I know that our systems don't give us the time. That wasn't the normative statement, but If you happen to have the opportunity to sit down with a patient and talk to them about how they're making these decisions, they're not looking at their health as this like special good that everything else falls under. They're balancing health with their finances, with sending their kids to school, with all this sort of stuff. And to tell a very quick story, when I was in grad school and I was doing my PhD, I was doing a paper on how people balance health versus the risk of impoverishment. That was my third paper of my dissertation. And I was asking initially, just kind of doing not even structured qualitative work, just talking to people about that. And I was in Madagascar at the time, and I talked to a colleague of mine, and I said, "Hey, let's say you're having to make this decision about, getting a treatment for a lethal condition, but you would have to, sell your livelihood. You would have to go broke because of that. How would you choose?" And then I asked specifically, what if you're making that decision for your child? How would you choose if your child was the one that was sick? And without missing a beat, he said, "Oh, no, no, no. I can always make another child. I cannot buy another farm." And as an American, I was like, oh my God, that is awful. How could you even think about saying that? And every Malagasy person at the table agreed with him. So we've got to be aware that we're bringing in a bias into these conversations, that we think everyone could never say that about their children, but people are making these decisions in a way that we don't even know all the stuff that they're balancing in their heads, and nor do we have the right to tell them how to balance these things in their heads.
And so then how did you respond to that in the end, Mark? Or how did you end up learning to try and confront that kind of disjuncture between what you believed and what clearly the population you're serving believed?
I mean, it's to some degree, it is not my place to tell them how to value things. This paper that I was talking about, I ended up not being able to do in Madagascar simply for funding reasons. I ended up doing it in the US. And even in the US, we don't, we value our health above other things, but we value our health on average about 5 times more than our financial solvency. So like, even in sort of even in the richest country in the world, we are making these balances. And I think what we have to, as practitioners, come to become a lot more comfortable with is talking about that to our patients, is asking that in a way that allows the patients to say, you know what, no, I'm not going to pursue treatment because it'll feel uncomfortable to me as a cancer surgeon, but that is a decision that they have to make, and I have to be comfortable enough opening the space for that conversation to be had.
So interesting. That issue of how we as clinicians can open up the space for people's deepest values, desires, what really matters to them to come up to the surface. And so, Maria, I'm thinking about some of the settings that you've been working in, which, have gone from like post-hurricane relief zones to Ebola treatment, and everything in between. But I guess my question to you is, and it kind of picks up from what Mark is talking about, which is the real question there is, whose values count here? Like, whose values are we prioritizing in this situation? And I wonder whether you can reflect on that. Like, what have you seen where those things have come into conflict, and how do we try and resolve them in practice?
Absolutely. I mean, two things came into mind when Mark was speaking, and the first one was absolutely what I experienced during the Ebola crisis in 2015 in Liberia, which was the gentleman who gave us the debriefing, or sorry, kind of the briefing. So before we were deported to Liberia, we were meant to go to Sierra Leone. And then last minute went to Liberia because an individual got infected, a doctor got infected right before we left. Um, he was really upset because he was used to palliative care in the US when patients are dying. And the thing that he was most upset about during his time in Liberia was that he didn't have morphine to give the patients before they died. And it was really interesting because one of the first things I discovered from speaking to the locals, and like I said, our logistics team was incredible. Some of the things that Mark touched upon is so true, that actually logistics make way more of a difference with organizations than we do. was that morphine was extremely looked down upon because morphine was used on the child soldiers during their 18-year civil war so that they could kill without feeling it or be numb. And it's extremely, if you said to a patient, I'm going to give you morphine, that's it, the trust is gone. They think that you have, ill intentions. So that it's one of those things that, before you go, you don't know these things necessarily. You're not, unless someone tells you, or, you actually happen to read it in one of the historical books, and realize that these little nuances in healthcare are really important. And these factors that we value so much in the West, or in developed nations, aren't the same when you go and practice clinically. Um, One of the trips I had to Mamallapuram in India, where I went to a leprosy colony, one of the things they had us do was very simple. We just held the hands or the stumps of leprosy patients when they went to the treatment in the hospital. So I had a patient who just had a routine ophthalmology appointment, and I had a gentleman come up to me and literally said, "Thank you for what you're doing because I wouldn't do it." And so our whole point was to show citizens nearby and locals that, look, they're treated for leprosy now. They're no longer infective. It's long-term leprosy, and pardon me, Hansen's disease is the term we prefer now. And so um, it was kind of eye-opening that, even with us doing that, even though it's great and we show that we're not afraid and we're doing it, people still aren't going to do it because of stigma and taboo.
Yeah, fascinating. And so you've both now brought up this issue in different ways of otherness and how we in medicine other our patients or can other our patients, whether we mean to or not. Because the truth is that medicine is not above racism and it's not above sexism and it's not above coloniality, and in fact was central to the colonial project. And so, which makes global health actually incredibly fraught, right? It makes it incredibly difficult to do this in a way where you can be reflexive and understand your positionality and yet use your power for good, right? Because that's ultimately what we're all trying to do. Now, Mark, you're editor-in-chief of BMJ Global Health. And in some ways, you actually sit in a position of even greater power and influence over the knowledge that we have at our disposal and what gets amplified. And I'm not asking you for your your agenda as editor-in-chief now, but I am wondering about how you think about your responsibility in a field that has been at least criticized in the past for reproducing those colonial patterns of power. That was a tough question, sorry.
Yeah, small question for answer that in 3 minutes. Before I answer that, though, Maria, just as you were giving that image of being in with the patients with Hansen's disease, I'm old enough to remember Princess Diana and Ryan White at the beginning of the AIDS epidemic, the hemophiliac boy who contracted HIV from a blood transfusion, and her, reaching out, and I forget if she shook his hand or touched him or somehow to break that stigma, to say, look, you don't have to be scared. Just those small actions, hugely, hugely powerful. Anyway, side note, let's talk about colonialism and global health. Look, you're right, rightly criticized, and continues to be rightly criticized. Global health for perpetuating colonial norms. Some of it, I think, the most trenchant and most difficult part to combat. So let me back up and say, we can and do put some guardrails in place. Unless there's strong reason otherwise. For example, no paper gets published from a country without authors from that country. So trying to prevent extractive research. So we can and do put guardrails in place. A much harder thing to address is epistemology. Like, how do we as people in the global north know something, and how is that intertwined with our own colonial constructs of what knowledge is and what counts as good knowledge? And that's a really hard one to, I will admit, that's a really hard one to untangle. I am foundationally a quantitative researcher, and boy, is quantitative research a particularly kind of enlightenment centered and global north centered way of doing research. So how do we start to make room for other forms of knowledge generation within the constructs of the current academic publishing system, or do we have to blow it all up and start all over again? I don't have a good answer to that. I just know that that's probably there's an even more trenchant version of colonialism that is a lot harder that's going to be immune to, like, well, just make sure there are enough authors from the country in question.
Mm-hmm. Totally, because and I can say this from the media world, you can just have tokenistic representation, which means nothing in terms of actually the agenda that is set and the conversations that you're having, right? That was a really tough question, Mark. I wasn't really trying to put you on the spot. And you on your own cannot reverse centuries worth of thinking. And as you say, epistemology, which is this understanding of how we've come to our ways of knowing, right? But that thing that we talked about before, even when we think about values, how can we as clinicians somehow understand that our way of knowing is not the way of knowing, not the only way of knowing? And how can we still operate within the framework that we have? We only have biomedicine right now, right? We have that as our framework. We still have to operate. We still have to do the life-saving, but we also have to try and treat people with respect. And now, Maria, I want to turn to you because as a woman who's working in these contexts, different cultural, institutional contexts, how do you feel that identity has shaped how you have been perceived, perhaps, in that setting? And I mean, I guess as a little follow-up, like, what ethical responsibilities do you think we have as clinicians with positionality, with whatever positionality we might hold?
I think I've been fairly lucky in most of my experiences, that, where I've traveled to and where I've gone, um, I wasn't seen as the senior usually. And so it was a little bit different, than currently in terms of as I transition into pediatric surgery. But basically before, when I went, I would say most of my experiences, was very warm and welcoming as a female, and not looked differently. However, we did have an incident in Liberia where the director who was in charge of the ambulances. So during the Ebola crisis, I was lucky enough to go into the rural area. So I was one of the first groups to go into the community, near March 2015. So we weren't in Monrovia in Liberia. We were in Zwedru, Grangita County. And because it was a much more rural area, the Ebola treatment unit that was set up there meant that when we took bloods from patients, it would take 6 hours on a motorcycle to get to Monrovia. And that's just the first test, and you have to do two to confirm that they don't have Ebola. So we had a director of ambulance services who would go out, and pick patients up or transport them and then coordinate the motorcycles. However, the overall leading person was actually a female nurse. And so she was coordinating the Ebola treatment unit, the volunteers in terms of the local hospital, Martha Tubman Hospital, and the rural communities, and health centers that we were at. And there was lots of friction, and it was definitely down to her being a female, and she wasn't respected, and she asked us as a team to complain about him, or put in formal complaints to Partners in Health when we got there, and we were seeing this hands-on, and it got into a really sticky situation. So it was really difficult, to balance that, and it caused a lot of friction with the team. And I actually finally stepped back at one point and I said, I don't know why I've gotten involved in this. I'm here to take care of patients. And I spent more time at the hospital, taking care of patients, because it was only me and one other clinician who had pediatric experience. So I was mostly rounding on the pediatric ward, most days. So yeah, I think it's really difficult in some situations, and you have to balance the culture of the community with your international organization, whoever you're with, and try your best, to say, this is the problem, this is what we're facing. how can we get around it? But unfortunately, that was a big one that made it really difficult to coordinate care, because sometimes he just disagreed with her triaging and just thought, well, I don't need to go out and get that patient and bring them to the Ebola treatment unit. And that was the biggest problem we faced.
It's so fraught, isn't it? Because you're an individual, and I'm sure you felt responsible for everybody or everything in that situation. You felt responsible to that female nurse, but you also felt responsible to your patients just to get on with your job. And you felt responsible to your organization who's sent you out there to get the job done. And you felt responsible to the population, to the culture that's, the hegemonic thing that's going on there. And what's interesting to me is that whether you're abroad or whether you're in the UK dealing with austerity cuts and looking at how it's just, beds are cut, nurses, there aren't enough nurses, nobody's getting paid enough. These are the same problems, they're just in different settings. But where does the ordinary clinician draw the line with their responsibility? And that's one of the questions that's been like driving me for many, many years now, is just to think actually where do I, as a clinician, draw the line with what I'm responsible for when it comes to things like the social determinants of health or these issues of positionality and power? Because at some level, there's only so much that Maria can do in that setting, right? She can't actually challenge maybe the person who's in charge or the person who's, behaving badly without some kind of cost to themselves. And so I guess what I would like us to now be thinking about is this moral distress that occurs when you're in that situation, right? Where you have a desire to maybe act or behave in a certain way, but the conditions and the systems that you work in don't necessarily enable you to do so, or in some cases, literally obstruct you from doing that. And Mark, I remember when we talked, you mentioned, or you talked about this idea of how the tendency within clinical medicine is to focus on one patient at a time, the individual patient. And yet that, ironically, you might think, oh, that's good, and keeping my head down, I'm not getting involved in politics, I'm not getting involved in the systems, but actually can burn you out more. And I wondered whether you could talk a bit about that, because I'm sure the people who have joined us today are always at that. They're trying to walk this tightrope between system and individual. And how is it that if you focus on the individual, it actually burns you out more?
Again, you're really good at asking really hard questions. This is good. A couple of thoughts on this. When we talked a couple of weeks ago, Guddi, we talked about, where does health end?
Mm-hmm.
And on some level, there, at least in the public health space, the unofficial answer is basically health ends at what touches your body. So like my eyeglasses are health. A wheelchair is health, but a wheelchair ramp is not health. Even though we do know that each of these will improve health, the wheelchair ramp will improve health, people, who use wheelchairs. And the other thing I want to say before I try to get into your answer is that I know sometimes in the global health conversation, there is a bit of a friction between the focus on the patient in front of you group and fix the road networks group and fix the colonialism behind why the road networks are the way they are. And people do tend to kind of get entrenched in one or the other. And the folks who are, relief focused will say, sure, like fix the road networks, but hundreds of thousands of people are going to die in the meantime. And the development folks will say, gosh, if all you do is focus on the patient in front of you, then the line of patients is never going to get shorter and you'll create dependencies. And the problem is they're both right. The problem is there isn't actually a right. They're both right. So I do think we are, to a degree, called on, as folks who work in global health, whether we tend towards the patient in front of you side or the system side, we've got to think about both. We've got to make decisions for the patient that take into account all these other things. I have dodged your question so far. To your actual question, I think part of what happens with moral injury, especially for clinicians who are focusing on the patient in front of them, is that these systems are the reason that patients are presenting in the ways that they are. And the systems are the reason that we don't have the treatment capacity that we know we could have to treat these patients. And yet, as clinicians, we feel like we have been tasked with, gifted with, called from on high to take care of all these patients. And so we've got this huge value focus, which is what makes us good at what we do, but is also what makes us susceptible to being used by the system to enrich other people's pockets, and also makes us susceptible to not paying attention to when it's time for us to pull back and for us to say, I can't like this, I cannot do this anymore. And so we end up getting burnt out because the system is built on our backs to enrich other people. And yet we have this moral obligation to take care of the patient in front of us that really does tend to lead to a lot of burnout. It's why between 60 and 90% of physicians in the US will complain of being burnt out and plan to quit their practices in the next 2 years. That's why those data points are there.
And yeah, so again, even though you dodged my question, everything you said was was fantastic, Mark. And that last thing that you brought up is very close to what I'm researching in my PhD right now, which is what should medical professionals do if we take the social determinants of health seriously? And what came up in the interviews that I did with clinicians on the ground is exactly what you just talked about, Mark, which is the hero mentality within medicine is killing us because we believe we have to keep going, even when our systems are literally hamstringing us, are literally making our jobs more and more difficult every single day. And in fact, it's not just because they're like cutting our resources, but they're making our patients sicker in the first place. And so there is this really interesting like dynamic here between the individual and the systemic, which is not easily fixed by any means. But you're right that in some senses, by trying to ignore one or the other, you're not going to get any further. At some level, maybe it's a coping mechanism, but ultimately down the line, it's really interesting. Like clinicians who have that awareness, which is a growing group of us, it's not an easy dilemma to resolve. Now, Maria, when you've been working in your different contexts, I'm thinking particularly in the post-hurricane context, you must have had to grapple with this idea of there's just not enough. There's just not enough. I can't do this. I can't actually save everyone here, or I can't do what I want to do. I'm wondering whether you can talk to that kind of moral distress, where literally in the place that you're working, like how do you handle that when you know that you could do more if there was just more around?
I mean, yeah, we had that in both Hurricane Sandy in New York City as well as during the Ebola crisis in Liberia, of course, is uh, during Hurricane Sandy, I think a lot of the most surprising factor with the homeless shelters that wasn't really thought of or planned ahead was New York is great at basically taking all these schools and being like, this is now a homeless shelter. We have to get everybody off the streets during this horrible weather. And, having clinicians um, volunteer overnight. So I did an overnight shift in a elementary school that basically took guys off the street, men and women, and then housed them. But a lot of them were withdrawing from alcohol. That was most of the calls I got overnight was they said, you stay here with all the medical equipment, but it was Band-Aids and Tylenol and ibuprofen. That's about it. I had very little to actually give patients overnight. And so the best thing I was able to give them was Benadryl to help with their withdrawal symptoms overnight. And just had to make that call whether, someone got ill enough to actually call an ambulance or not. Luckily, we didn't get to that point. But you see this in many situations in terms of having limited resources. The most stark one that I experienced was what a lot of people didn't realize during the Ebola crisis is, of course, that vaccination distribution got cut off during crisis. And, we saw that with COVID as well and different epidemics and pandemics. And so the worst thing I actually saw was an 11-year-old survived tetanus, but we had a measles outbreak in one of the villages, and a 4-year-old boy who came to us was breathing 80 breaths per minute. And luckily, one of the doctors that came, her hospital had put all these funds together to donate a little portable ultrasound so we could see that he had dilated cardiomyopathy. And so we literally could only give him fluids and furosemide, fluids, furosemide, fluids, furosemide. I actually swore he was going to die in 2 days, and I was shocked that he actually survived. But yeah, you have in many of these situations that you're dealing with limited resources, and you just can only do your best in that situation.
Again, just so powerful to hear from your experiences there. And I realized that I could happily talk to you both all night, but um, what you have done fantastically is help to make what sounds very abstract become very concrete and very poignant, I think, actually, through your lived realities and some of the tough choices that you've had to face and what you've come up against. Now, as we transition to the breakout rooms, which is where we'll ultimately like everyone to get to, I'm just going to open up the whole floor to anybody who would like to maybe ask directly to either Mark or Maria a question, or maybe they would like to respond to something that they've said, because we've had some incredible stories just shared now, but I know that the audience themselves have things to say. So just for a few minutes while we're figuring out the breaking out, is there anyone who'd like to join in with the conversation and speak up? Because now is the time.
Mark, I was going to ask a question. You're talking about the literature and other ways of knowing. And do you think there are ways that one could actively support that the other ways of knowing to be published, if that makes sense? Sorry, I'm not sure I worded that correctly, but you talked about kind of the way we research traditionally done in the West and how we can capture those other ways of seeing the world, thinking more about kind of qualitative research, ethnography, and that role in informing medicine and policy in a meaningful way.
Yeah, Helen, that's a great question. And I wish I had a better answer than a formulation of the question. I think I can formulate the question without actually having a good answer to it. Things like ethnography and medical anthropology and things like that I think, are a step in that direction, but they are still on some level rooted in I might get in trouble for saying this, but they're rooted in whiteness. They're rooted
Yes.
in
You're not going to get in trouble for that.
And how do we even, so I'm Arab by descent. How do we bring in the knowledge that is in our oral histories, in our oral traditions of whatever culture that we come from, that we have tended to discount? What is its place? And even as that came out of my mouth, the positionality of that statement, that I, as the editor-in-chief of BMJ Global Health, gets to decide what the place is for traditional knowledge. But how do we even just open that conversation up to make it a little bit more concrete? One of the things that I think about a lot, working particularly in West Africa, is the patient pathway very, very, very often goes through the what we almost derogatorily call the traditional healer. And you'll see a patient who has spent a lot of money and spent a lot of time and therefore delayed diagnosis with these traditional healers, which didn't work, in quotes, to treat their tumor. But on the other hand, what did it do? It did things. And is there a way to approach traditional knowledge that is a true accompaniment and true partnership, as opposed to, okay, yes, we will maybe incorporate the traditional healer on the way to getting their real surgery. And again, it's stuff that I am thinking about, but I have no real answer to, except that every time I try to answer it, I end up with my own positionality being like, oh, well, I get to decide what the right answer is. So I wish I could give you a better answer, Alan, but it's a great question.
This is the problem with philosophy, isn't it, Mark?
So I became a surgeon, Guddi.
Are there any more questions for either Mark or Maria before we break out? Looks like someone called Nicolo.
Hi, yes, sorry.
I'm sorry if I pronounced your name incorrectly.
No, that's exactly correct. Thank you so much. And thank you so much to the both of you for running your insights. Sorry, I feel like a bit of an imposter in this call because I'm a foundation year 2 doctor. So I'm very early on in my career, and I was sent this link by Professor Devakumar. But I guess maybe providing my own perspective on things and posing the question to the both of you is, I guess, coming out of medical school, wrong, fresh out of medical school, we did have these lectures on the social determinants of health at UCL actually. But that only formed maybe 5% of the curriculum, whereas it ideally should have formed far more, far more part of the UCL curriculum, really. So much so that it almost felt tokenistic that they included it as if to say, well, we're thinking about these concepts, we're going to include a little bit of it, but that's it. And that was kind of reflected, I guess, in the attitude of some of my peers to it, which was a bit frustrating. These lectures were, for lack of a better way of putting it, poo-pooed by some of my peers and friends by saying, well, these concepts are common sense, so we don't need to go to them. But, well, if it's common sense, then why aren't we doing more about it as students and educators and clinicians, future clinicians? And that kind of has translated a little bit, well, from the small area of medicine that I see in my own practice into some of my colleagues as well. Well, some of this stuff is common sense, and we can easily sort that out, but no one's really doing anything about it. So that attitude kind of permeates, I think, through lots of future clinicians and clinicians today. Whereas you feel as if you're almost in the minority. And I think this is a roundabout way of asking you, what do you think needs to change in medical education to change this attitude that people have, where people almost push it away, say that it's common sense, not my issue, I'm here to tackle the patient in front of me and nothing else? Because that was a little bit frustrating, I think, observing that in my own colleagues and peers, the majority of whom seemed to have adopted this attitude.
Thanks, Nika. It's really great. So first off, I was F2 not too long ago, so don't worry at all. You're completely valued, and the important part is that you have these opinions and that you're, expressing them and coming to this, and that you carry them through your career and into global health if that's what you end up doing, which will be great. And so I would say it's really tough because every med school is different. So I went to Kiel, which is, based in Stoke. And because we had PBL, it was ingrained throughout the like almost every PBL case. And exactly what you said, some of the things that came out from students early on is shocking, kind of old stereotypes in terms of, oh, all these patients have COPD because they smoked for years and so they kind of deserve it, or, different factors like that. And I think it's really hard because both I think in the States and the UK, but more, I think a little bit more in the UK, the majority of medical students still come from wealthy backgrounds and are very protected prior to medical school and really through medical school. Like I actually had no idea until fifth year medical school that the majority of my classmates were having their meals made by their parents every single day. Like they would go to London every weekend to get entire meal plans and like bring them back to Stoke, or their parents would come to Stoke. I had no idea. I was shocked. And so yeah, I think it's really hard, and I think medical schools should be held accountable and need to do more in terms of integrating social determinants of health within their curriculum. You're absolutely right.
Mark, did you want to add anything?
Let me just hop in. First of all, 100% agree with everything that Maria said. If I may, there is something positive about people saying, oh yeah, of course, that's common sense, because that is a change. That is already a shift in the way the conversation has gone. For us to even recognize that these things are now common sense, which, let's be honest, they are. It should be common sense that things like financial barriers, et cetera, are interfering with people's health. So to even recognize that is actually a really good thing. That is a move, that is movement that has been made. at the same time, fully agree with Maria that a lot more needs to be done to change the way that we as doctors think, so that even if what we want to do is care for the patient in front of us, we should at least think about that patient as a holistic individual who takes into account all of these things and for whom your treatment may affect these things as well. Like if I'm speaking as an American, where it costs you, $100,000 just to sneeze, but that will affect your own financial future, and that needs to be in the patient's mind. So I do think there is more that we can do as educators and as senior clinicians to implant that into our heads, that if we really want to treat the patient in front of us, they are a multidimensional person that is thinking about all of these dimensions, and we need to be thinking about that too.
Nicola, that was a fantastic question, and I would advise you to join WHAM, because this is exactly why we exist, which is because you're right. You were at University College London. It is where Sir Michael Marmot did all of his research on the social determinants of health, and yet you have been indicated in the hidden curriculum that it's not that important. That is why the 3 ages of child had to be made, and it still won't reach everyone because the powers that be don't think they just don't see it as being like a priority, because it's not as sexy as the number of beds that are not, that are being cut, or like the amount of funding that's not going in the NHS. But Nicola, the truth is, it's just what Mark and Maria have said, which is that it is our responsibility at some level. And we need to figure out what that means, because it's not straightforward. It's not easy. We can grapple with it together. And that's what this space is for, right? For us to think about this collectively, not just as individuals, about what we might be doing about it. But I guess the idea for someone at your stage, I'm sure there's many people in that stage, is look for people who are thinking like you. And they won't be in the same institutions necessarily. This is why we are like a geographically dispersed group, but there's plenty of groups out there, plenty of people out there who are thinking like this. And ICHG is a fantastic group as well, who are also thinking about this. So I guess I'm trying to just make sure that you don't feel too disheartened or hopeless about it all, because there is hope, or there has to be, otherwise why would I be doing what I'm doing? So on that note of hope, I'm going to break us up into the groups. Well, I'm going to get Sammy to break us up into groups. And the idea is that we are able to talk, I think maybe for 10 minutes in our groups before coming back together, because there's clearly a rich conversation that's to be had. Sammy, I'm going to hand it over to you.
Yeah, perfect. So I've divided us into 3 groups, which either have 1 or 2 facilitators in each room. So hopefully everybody has been allocated now, and when I click open all rooms, you should automatically get put into your room, and then it will give you a 1-minute warning, and then everybody will automatically get pulled back to the main stage afterwards. So we'll have faith that the technology is going to work for us. If anybody finds that they have not ended up into a room, then please message on the main chat. If there are any issues, just refollow the link and it should pull you straight back in. But yeah, everybody has now been allocated. I'm just going to just because we've had a couple of people leave, I'm just going to move one person into the other room. And then I'm going to start. So everybody has a list of questions to discuss, and then we will come back and kind of discuss as a group afterwards. Enjoy. Oh, Nicola, you haven't joined. Right, let me put you in a room. Yeah.
Okay. Are we all ready to go? Yeah, okay, great. So welcome back, everyone. So what I thought we could do with this last closing 20 minutes is, and I realized from our particular little discussion group that there was so much to be said. So I feel a bit sad now that we've kind of cut the conversation short, but this is the opportunity for those conversations to continue. But I first of all thought that it would be nice for people, if they wanted to just report back on what the overriding theme was from your various groups. Because I think what I would love to do is to bring Mark and Maria back in to like maybe bringing some threads together for all of us together. Because the point of these discussions is, of course, to raise issues, but not to leave them necessarily completely flying in the wind. If there's any sense in which we can at least try and bring some of them together for you so that you're not left completely feeling at a loss, then that would be at least one job done. So, which of the groups, who would like to report back first?
Should I report back from my group?
Is there somebody from your group who would like to do it?
Well, yes, sorry, invite if anyone else would like to.
Yeah, not the facilitators. If there's somebody else, yeah.
I was going to nominate someone, but I don't know
Jess,
whether.
do you want to volunteer? You were very vocal in our group.
There we go, Jess. That's who I was going to.
Sorry, I was a bit shy. Hi, everyone. Yeah, a short period of time to talk about a really big question, but it's a really good question.
What was the question that you were discussing?
Oh, sorry, we were talking about the when the needs of the population does not meet what the commissioners want. So I'm a pediatrician in Manchester, and I certainly see this in multiple different facets, and mostly ranting about how we see this in multiple areas. We haven't really come up to solutions apart from the fact that those on the ground who sees the perspective of the patient and of their families really need to feed it back to the commissioners what they really need. Sometimes brand new ventilators aren't really as needed compared to actually some reclinable sofas next to the neonatal cots, so that the families can have time with their babies, or a new entrant screening needs to not be a postcode lottery, and around, at least in England, that certain places, new entrants certainly get more infection screening rather than others. So I think it's us being advocates as pediatricians, but also really going right to the front line to ask our consumers, our customers, our clientele, what they really need.
Okay, really interesting. Really good. And by the way, well done for doing that if you were feeling a bit shy. You come across as incredibly confident, so I don't think that was a problem really. I loved what you said there in terms of thinking about if there's a mismatch, what do we do? What's our response? And you're right, you didn't really, I mean, in a way, you did come to a solution in some senses, because this idea of advocacy is really important. And it is meant to be one of the roles that we think about as part of our clinical roles. And yet, how many of us are really trained to be an advocate? How many of us are really empowered to be an advocate? How many of us are protected to be an advocate when we actually want to whistleblow or talk about what's not happening and why our patients are not safe? I can tell you, we're not protected. We're not. So it's great on paper, and it's great when different medical institutions tell you that you should be an advocate, but actually in reality, we're not protected. And so I think one of the things that is probably going to come out of all of this is just that there's often a mismatch, isn't there, between what we want to do or what we believe is right and then actually what systems allow. Did anybody want to respond to, was it Jess? Sorry. Yeah, respond to what Jess brought up, because it was a fantastic point. Or we can shift to the next group.
Thank you, Guddi. I think it's just, again, it's so frustrating when a commissioner comes up to you and says, we get you what you're saying, Jess, but we just don't have the money. You magic up the money and work out from there.
What's even worse than that, Jess, is when they actually tell you just like, okay, that sounds great. It's common sense. Draw up a business plan. Tell us how many lives you're going to save, or tell us how much money you're going to save this unit. And you're just kind of like, the kid's hungry, like feed them, Anyway, so that's just like personal frustration. But yes, absolutely. Anyone else, any other group, or a response to Jess's comment?
I think misallocation of funds also gets really frustrating. So at Alderhay Children's Hospital, their big push last year was that they built a cinema, and we have this amazing cinema in the frickin' hospital for pediatric patients, which is incredible. Yeah, we get to bring them in their wheelchairs and their beds to this cinema, but the computers don't work. And it's like, you want us to be all electronic and, get our jobs done, but you won't fix the computers and you won't replace the computers. So yeah, I think that goes along with that, with the frustrations is, even, even the simple things when they have this big project and then all of a sudden all these emails come out like, oh, actually we need to save 25 million this year. So we need to figure out where to make cuts and save money. I'm like, oh, maybe you shouldn't have built a cinema. So yeah.
Maria, I can't tell whether you're talking about Aldi, hey, or the UK government. Like which
Yeah, maybe I shouldn't have named it with the recording. Yeah, probably
Well,
should have thought of
we
that
can
first.
do something with that. We can, I'm
It's
sure we can.
okay.
Yeah. Um, were you in the same group, Maria? Was that were you in a different group? From
No,
your
we were in a
group,
different group.
Maria, was there anyone who might be willing to share what was discussed in
I think so. I think Tabby made really good points. Jade was talking right at the end, so she got cut off a little bit. So I think if one of them want to speak up, or Maria, that'd be.
They're not coming forward.
I mean, sorry, can everyone hear me?
Yes.
Yeah. I feel like people said lots of really interesting stuff, and I don't know if I'll do it justice by remembering it all. But I think we started off we were thinking more about the how we collect research, and how I was saying I did a BSc I integrated last year in global health, and I was quite frustrated. There was a lot of things that were really interesting and useful for my dissertation, but because they weren't what we would consider randomized controlled trials and things like that, I just wasn't able to use that. And it was just very frustrating, really. So, and then I think Jade at the end was talking a bit about Maria actually was saying how we could integrate research and being a clinician rather than having them so separate, trying to really fuse them together. And there were lots more interesting points, but I don't think I can succinctly remember them well enough. So if for anyone else that I've forgotten, I think other Maria also said lots of interesting points. So
Tabby, that was fantastic. And you have brought up some really interesting issues, which is, again, that issue of like whose knowledge counts, and how do we weigh up, the relative value of different kinds of knowledge, even within biomedicine, right? So the randomized control trial is like absolute gold standard. And, what does that mean when actually maybe in actual personal clinical practice, that drug doesn't work? How do you then like weigh up these things against each other? And I loved what you said there about, can we not just be more than one thing at one time? Can we not be a researcher and a clinician and an advocate, to go back to Jess's point, and I guess, public communicator in my case, or like with Mark, who's writing books and he's an editor of the journal. Partly why we run these webinars and why I'm trying to introduce you to fantastic people like Maria and Mark is because I want you to see that there is not one single way to be a clinician, and that actually we should all be thinking about our roles in much more expanded ways than we are trained to or taught to. Because it's just, well, I think more is actually required of us than the job description. And until people have figured out exactly what our jobs are meant to be, we have to be doing that figuring out. But that's fantastic. So there should be 2 other groups, or just one other group? 2. 1.
So yeah, from our group,
Yes, well
with
done,
Mark,
Kaushik.
yeah. So we actually didn't get to our ethical question. We decided to forego it and have a more of a collective discussion on what's bothering us. So we decided. So our discussion mainly extended to how our job forces us or pushes us to stretch ourselves in different ways, and what's the cost of that to us as clinicians. And Mark spoke very well about how protecting ourselves, how we can protect ourselves, and why that's important, and how I think it's imperative to protect ourselves because we are cogs of a process that helps people on a longer scale of time. So that was our main focus, is how do we deal with burnout and what it means, why we should reframe burnout into other words which don't put the onus of it onto us because we are the ones suffering from it. It's more like you're blaming the victim, and we have to move that narrative away from that. So that was basically our discussion, and I think we were just trying to put up help ourselves rather into not feeling too bad that we aren't doing everything in our power to help everybody, but that we are doing enough, and we can keep doing enough.
Brilliant, Kaushik. That's a very good summary. And if it's okay, I would like to just revert back to Mark on this, because Mark offers, at least in some sense, some respite from all of this. So Mark, this could be a little plug for you and your book and the work that you do, but can you just tell people about how you actually help people, clinicians like me, who are struggling at the coalface with thinking about how can we juggle all of these responsibilities and how can we avoid burnout in our careers?
Yeah, I'll try to be brief because I know we've only got 10 minutes left. I mean, Kaushik really started it. Started the explanation. I mean, the word burnout is a victim blaming word, because the fact is you cannot yoga your way out of a system that's built on your back. And so I think we've got to first start by saying this is not burnout. This is not just that we've worked too hard. It is moral injury. It is demoralization. It is all these other things. And it is not our fault. In fact, it is the fault of the system that has put us in this place. The other thing that I said to the group, so I actually spend a lot of my time right now coaching mid-career health professionals who are like, I loved it for the first 15 years, but I cannot keep going. What do I do with my life? And there's a lot that question is particularly hard for folks in what I call the identity professions. So medicine, lawyers, clergy, teachers, for whom you're not just working as a teacher, you are a teacher. You are a doctor. So your identity is intertwined in the thing that you do. And that, I think, Becky, you were the one that sort of said, that kind of made the implication that, I've started as a pediatrician and therefore I must continue to be a pediatrician for the rest of my life. That is eminently not true. And if we look at careers outside of the identity professions, they change, they evolve. Prior to this job that I have at BMJ Global Health, I was the CMO of a big healthcare charity. And the COO, the chief operating officer that I worked with, started his life in mobile phones. And then he went to aviation. And then he became the COO of a medical charity. And nobody ever looked at Robert and was like, look at you, you're such a flake. It was just a normal progression of a career as, in the sort of project management side of things. But they look at us, and you start as a pediatrician and all of a sudden you're hosting a radio show and, oh my gosh, what the heck happened to you? Which is it's an added victim blaming. It's an added victim shaming that you've had to protect yourself. So I think broadly, and I can talk about this forever. Broadly, we have to come to grips with the fact that we were drawn into this profession because we want to do good in the world, help people, whether it's the individual or the systems that we've been talking about. And that is our calling for now, but it does not have to be our calling at 56. It does not have to be our calling at our retirement. We are allowed to have careers that are protean, that serve us in addition to the patients and the systems that we're there to serve. Okay, I'm going to shut up because that was already
nice. No, nice. Thanks, Mark. Really good. So I think there is one final group that needs to feed back, if I'm not mistaken.
I think that's it. There were 3 groups. So
perfect. Amazing. Our timing is absolutely impeccable. Brilliant. So in that case, I would like us to finish just kind of, again, bringing those things together and actually letting Mark and Maria have something of a last word, although there will be a last word actually from Sammy and I at the end. But for me, at least, there were numbers of themes that came up, and maybe I'm just going to say a few just so that you're not on the spot, Mark and Maria, to kind of come up with something. But please, reflect back for you what you've heard, because I feel like we've heard about this push to be the best clinician you can be, right? That's kind of the way that we're all trained. We are set out the gate, be the best clinician you can be, and yet the world does not allow us all of the tools and resources that we might have to do that job. And so I'm wondering about how can we be advocates, like Jess has been talking about? How can we confront and expose when resources are not there, and they should be there when there's a misallocation of funds because Alder or whichever hospital has decided that they want to spend it in the wrong way? And how do we also call out things like when knowledge is being abused and different people's knowledge is being abused? And I'm wondering that so much of this, Mark, is just what you said, which is that it's individualized. We are blamed, or we are then made to take the burden of whatever's going on. But how do we collectivize to tackle some of these issues in a much more systemic way? Because it is systems that have brought this on us. How do we then turn that focus onto systems so that, yes, we can be a good doctor, good nurse, whatever health professional we are, but so that we can also ultimately save ourselves as opposed to just saving other people? Because I feel like that's what came up definitely in our group, was just that we can't be sacrificed for this. Otherwise, there'd be no one left to do the job. And so Mark and Maria, that was my kind of like sense of what came out of the discussion, but I'm sure you guys have much wiser things to say.
No, I think the dichotomy that Mark talked about earlier goes along really well with what you just said in terms of no, we need to fix the roads, no, we need to take care of these patients. I think as a clinician, it's the thing that I learned the most from my humanitarian aid is that actually we're nothing without logistics and we're nothing without the systems. I couldn't do anything that I did without the local people. And that's what I love about Partners in Health is they hire everyone that they can locally and have as little volunteers as possible to make a difference because they want the system there to improve and they want to hire local people to make everything better. So I think you just have to, look at the hope. And I would say people like Tabby and Nicolo, like they give me hope. I love that when we have medical students and, foundation doctors come to these things and share with us, it really gives me hope that actually there are people like us out there who want to make a difference and want to fight for social injustice. And it will keep happening. We will get there.
Nice. Maria for Prime Minister. So, Mark.
Yeah, you got my vote, Maria. I'm an American, so I don't know if it'll help, but got my vote.
Well, Maria's also American, but hey,
but hey, it's true.
She's on the wrong side of the pond.
The one thing that I will say to end is just to encourage you all of us here, to never stop asking the question why. You see something in front of you, why is that there? Not just pathophysiologically, why did that salivary gland turn into a tumor, but why is that there? What's underneath that, and what's underneath that? And let those questions change you. I think I'm speaking for you, Maria, but I suspect my work in global health has deeply changed me and the way I approach the world. I suspect it has for you, Maria, for you, Guddi. And I think just let your experiences, let the world, let your patients and their stories teach you things that you're just never going to learn in the textbooks.
Brilliant. Wow, amazing. And I hope inspiring for everyone who's listening, because as you've heard tonight, there are definitely no simple answers. Nothing, I can't give you any tidy little things to take home, other than there is lots of hope in this room. There's lots of inspiration. There's lots of signs of the future, which is very, very encouraging. You're right, Maria, like it's great. I want you to feel like you have met your colleagues of the future. Whichever organization you happen to be a part of, whether it's ICHG or WHAM or whatever, we are friends. We are allies. We are trying to do this work together. And across the pond with people like Mark, we are thinking globally. We're not just thinking locally, right? I think I would like to just make sure that we thank Mark and Maria for their time. They have been absolutely phenomenal. Their contributions have been such high-level interventions. I am so, so grateful to you both, but also just so impressed by both of you as individuals. You're incredible human beings, and I'm really, really glad to be able to say that I know you. So thank you. Now we will end with a few notices. Sammy, do you want to put my slide up first or your slide up?
Yes, I will put your slide up.
Lovely.
There you go.
So this is just to say, thank you, Sammy. So this is just a very quick thing because it seems like lots of people, lots of young people do want a place, a home to go for the questions that were raised in this discussion. I am not saying that we are the final word on this, but we are a place, we are a home, we are safe, we are really warm, and we are actively grappling with the questions that have been raised in today's webinar. So please join WHAM if it seems like it's the kind of community you want to belong to. If you are just curious and you want to see what we're up to, we have an Instagram account, very new. So keep watching that space. Even I joined Instagram, which is like saying something. And we would love to know what you thought of today's webinar. So that final QR code at the end is a feedback form. And I know nobody wants to fill out a feedback form, but if you believe in the future like Maria does, then we need to know how to make our offerings better. We need to know how to meet your needs better. So please do fill out that feedback form. It will be useful for us. It'll also be useful for the ICHG, I'm sure. But yeah, essentially what I'm trying to say is WHAM is a family. The doors are open. Please join. Sammy, back over to you.
Brilliant. Thank you so much, Guddi. I'm just going to share the ICHG slides now, just for a few upcoming events. Can everybody see that?
Yep.
So again, this is our, let me just go to the beginning, 1 second. Here we go. So if anybody would like to join the ICHG to get our newsletters, hear about other upcoming events, this is our QR code here. We have a year's free membership for students, and also for anybody from low and middle income countries, membership is free. We have different streams. We have advocacy, research and education streams, which are all aligned with a kind of common ground of striving to improve health of children around the world. And we're open to any child health professionals, any allied health professionals, etc. We have, there's a webinar tomorrow, actually, it's a busy month for us, that's with the research stream in collaboration with the RCPCH Trees Network. And this is looking at combining paediatric research overseas with UK-based training, and is we're going to be hearing from Dr. Joe Piper, who's currently working out in Zimbabwe and is a paediatric infectious diseases trainee within the UK. So there's a link there if anybody would like to join that tomorrow morning. We would also like you to all save the date for our upcoming annual conference, which is later on this year on the 26th of November, with the subject Hope Across Borders, Protecting Children in Global Health Crises. So that's going to be a really fantastic event, and more information will come out closer to the time. And just to say, if
next year, it said 2026.
Oh, this year, 2025,
year.
2025. And we have a couple of committee roles available at the moment. So there is an opening for an education and training co-lead to come and join myself. And we also need a new secretary. So if anybody is interested in either of those positions, would like to know more, please get in touch with us if you have any questions, or if you would like to apply, we just need your CV and a short paragraph or up to one side of A4 about why you would like to do the role. And that's to intchildhealth@gmail.com. And that is all I have to say.
Lovely. Thank you, Sammy. Okay. We've only run over by a few minutes. I think that's okay. I think that's allowed. Once again, massive thank you to ICHG for co-hosting this WHAMinar. Sorry, it is a WHAMinar with us. We are absolutely delighted to be able to partner with ICHG. They are an incredible organization who are doing really good work. For anyone who's not a child health professional, WHAM is definitely a home for anyone, not just pediatricians or people in child health. But big thanks to Mark and Maria for joining us from across the globe in some cases, for your time, for your wisdom, and to everyone here who spent so much time absolutely wrapped in this discussion, which I have to say was very interesting, and I've made loads of notes. Please share this work widely, and please stay in touch. I am so happy to be in touch with anybody who's on this call to talk about anything that might be of help to you, whether it's careers or WHAM or otherwise. Please keep this community going, and yeah, hopefully turn some of these reflections into action. And on that, take care and good night.
Thank
Bye.
you so much.
Thank you so much.
Thank you.
Mark and Maria, can you hang
Thanks.
on just so I can, yeah.